Good morning, everyone. This is Marcus Stoddard with Cardiology. We have an exceptional talk today with one of our stellar members of Cardiology, Dr. Shahab Ghafghazi. He has been a director of the Cardio-Oncology program for several years and has been recently elected to become and is the director of our fellowship program. So he has very important job that he does with our division and has been a stellar contributor. But today he has taken his time to put together, I think, a very important and impressive talk that relates to coronary disease, but specifically management too. How do we manage, or do we revascularize our patients with stable coronary disease, stable angina, or do we take a medical approach? And what are the outcome differences and what are the pros and cons? And so I'm very intrigued to see what the results will be. I know there's a good amount of data and literature on this. So without any further delay, I'd like to introduce our grand round speaker, Dr. Shahab Ghafghazi. Go right ahead.
Thank you. Good morning, everybody. So I am going to, this is in fact a sequel to a similar talk that I did, I think in 2016, but some major data has been added to the literature, something that we've been waiting on for a long time, that I thought it's worth reviewing the topic one more time. Some of the slides, I'm doubtful anybody remembers what I did last time, but some of those is, in fact, repetition of what I did before. Just I thought that reviewing the topic, it's probably a good idea to add some of the, some of the old stuff that I've already presented once. So I'm going to start with a clinical vignette. So this is a 56-year-old man, hypertension, hyperlipidemia, presents with 1 month history of exertional substernal chest pressure. Exam, ECG, and chest X-ray are normal. Patient undergoes exercise stress test and a nuclear stress test. Walks on treadmill for about 6.5 minutes on Bruce protocol. With a peak heart rate of 140 beats per minute and a blood pressure that peaks at 212 over 112 millimeters of mercury. Patient stops due to chest pain, and SPECT demonstrates a moderate to large size area of apical, anterior, and septal ischemia. A coronary angiography is performed, and there's an 80 to 90% stenosis in proximal left anterior descending artery. So now the question is what to do with this. This is presumably the coronary angiography of this patient. So this is the left main coronary. This is the catheter injecting the contrast dye. This is the left main coronary artery, and this is the LAD coming down here. And as you can see, that pinch over here is what we're talking about. Okay, so this is a patient with stable chest pain, about a month of chest pain, a positive stress test, and an angiogram that you saw. So the question is what we're going to do about that. So let's have a philosophical approach to, any disease that we treat. We treat disease because we want to improve patients' survival, or we want to improve patients' morbidity and their quality of life. So are we going to be able to achieve any of that if we were to revascularize patients with stable coronary disease? Okay, so a quick historical look at where we were and where we are now. So it starts in the 70s when essentially CABG became mainstream. Was the only way to revascularize patients if you were to do something. And then we had some medical therapy at the time, was mostly aspirin. Later on, we had beta blockers and nitrate. So that was really all we had in terms of medical therapy. So that's in the 70s and 80s. This was a typical population of stable coronary disease at the time. And what's interesting is you noticed diabetes was about 10% and hypertension about a third of the population, but a lot of people smoked. The patients who went through this study, essentially randomized to CABG versus medical therapy, they had pretty much the same in terms of angiography features that we actually see today. So about 30% of them had single vessel disease, about 40% about two vessel disease, and another 30% had three vessel disease. In this study in particular, the ejection fraction was essentially normal. So this is the this is just one example. This is the CAS, coronary artery surgery trial that was done, and as you can see, the result of the two groups over here. This was about 700 patient population that were randomized. One of the very first randomized trials in cardiology, and you can see that the graphs are essentially overlapped altogether. There was another study a little bit older, the VA study from 1977, essentially the same result. However, later on during the in the 80s, a European study came out. This was the European cardiothoracic surgery study, about another, for 800 patients. And with this study, we started to see some difference. So probably as they got better, surgeons got better with CABG, we're able to offer more to the patients at the time. And then in the 90s, when all of this was looked at in a meta-analysis, so you can see that down here, you've seen all those three graphs. This is the VA, this is the CAS, and this is the European study. And so when you look at meta-analysis, there's not really much in terms of the difference, which makes sense. At 10 years, though, there was about it actually did show a significant difference. And if I show you how many patients were in this study, patients with three vessel disease, there was about 1,300 patients over here. And there was about 150 patients with left main disease. So this is the extent of the evidence that we had essentially for CABG. We were starting to see some benefit, and we really didn't have much of medical therapy beyond aspirin, beta blocker, and some nitrates. So then we essentially move on to the era of statins. That's what made it probably the most important difference in management of stable disease. We also started to have bare metal stents. So before that, again in the 80s, we had balloons. We were able to essentially open up a coronary stenosis, but we really didn't have any scaffolding to put there to prevent its rapid recurrence. And then we started having bare metal stents, which are essentially these miniature scaffoldings that we're able to put and open up and support a coronary stenosis that we have ballooned up open. But bare metal stents that have no drugs in them, so they are not able to prevent regrowth, this process of neo-intimization and smooth muscle growth that you get with after a PCI. Okay, so this is I found this in the literature. I thought that's kind of interesting, historical. This is the first case of coronary angioplasty that was done for stable disease. As I said, in the 70s, we didn't have any stents, right? So all we had was a balloon. So this is an LAD lesion. As you can see, that's very tight, which is ballooned open. If you compare with this one, it looks like a little bit further open. And then this patient is brought back about a month later, and it sort of still remains the same. Now, balloon angioplasty, had a significant rate of recurrence. So at 6 months, a large proportion of these patients essentially had recurrence. So that's essentially a historical matter at this time. Okay, so this is a meta-analysis of 11 randomized trials looking at the PCI. This is when we started to have these, bare metal stents, and compare that with medical therapy. Now, about 3,000 patients here. This is published in 2005. We've only just started having statins, and when you compare them, even then, you don't really see much of a difference. Look at the p-values. They're all essentially negative, suggesting that at the time, this is before the landmark Courage trial was performed. Even at that time, we were not able to demonstrate much in the way of benefit for revascularization, when it comes to real outcomes like death, MI, and so on. So then, we move a little bit forward. So now we come into 2000s. Now we have statins on a lot of patients. Multiple randomized trials of statins have shown benefit, and so we've started using them. So our medical therapy is improving. At the same time, we're also getting better stents. So we're starting to get drug-eluting stents, and essentially for people who may not be familiar as to what exactly that means. These stents have the same drugs that you use for chemotherapy and transplant. So there's paclitaxel eluting stents. There is everolimus eluting stents. There's sirolimus eluting stents. So essentially, these drugs prevent growth of the tissue after the stent is placed. So they sort of slow down and diminish that process of neointimization and the smooth muscle growth that we get after stent placement, and therefore they reduce that in-stent restenosis, so recurrence of stenosis in where the stent is placed, which nowadays they've become essentially the standard of care for anybody who undergoes PCI. Then we come to the landmark Courage trial. So in Courage trial, we used a first-generation drug-eluting stent. The patients that were studied, and I've put the two major trials here, Courage and Berry 2D. So Courage essentially we enrolled patients who had at least a 70% lesion in one vessel or more, subtending a large area of myocardium, and there had to be either objective evidence of ischemia or severe symptoms. A simultaneous study was a Berry 2D, which was done only in patients with diabetes, so a higher risk population. And patients had, again, at least one vessel that was obstructive, more than 50%. And there had to be an objective evidence of ischemia or, again, a typical angina. So these two studies were essentially done at the same time. Courage started in 1999. That's when they started enrollment. And Berry 2D started enrolling in 2001. Both trying to address a very similar question in slightly different populations. Now, so we'll go over the revascularization procedure as to what was used in both of those trials. So let's go to Courage trial. So it was published in 2007. They enrolled about 2,300 patients with stable ischemic coronary disease. As I mentioned, more than one vessel or more, and a fairly large area of ischemia on the myocardium. And they were randomized to PCI with this first-generation drug-eluting stent plus medical therapy, or medical therapy alone. So now this OMT stands for optimal medical therapy. The primary endpoint with Courage trial was death or MI, which is probably the most solid primary endpoint that you would use, death or death, MI, and stroke in cardiology literature. As I said, the patients were randomized into PCI and optimal medical therapy or medical therapy alone. It's important to pay attention that medical therapy was done in both groups. Patients were followed anywhere from 2.5 to 7 years. And this is essentially the targets for the risk factors. Now, have in mind, this trial was designed started in 1999, so they must have started designing the trial, in 97, 98. But a lot of the targets they actually had are very contemporary. So the stuff that we still use a lot of these targets. We want to go for smoking cessation. Our LDL cholesterol target is 70 now. and for some populations lower, down to 50. We actually do like to have a triglyceride target less than 150. The difference is nowadays we have better medications to try to achieve that. We recommend physical activity is essentially the same. That's not changed for the last 20 years. Weight loss is encouraged. Blood pressure target is essentially the same, and A1C target is the same. So just bear in mind that the targets were really very contemporary, even though this is from 20 years ago, although all the drugs that we have today wasn't necessarily available at the time. So just have a quick look at the population, and if you remember, I showed you that study from the 80s, the CAS trial. There was 10% of the population who had diabetes, and here you see about 30% or so. And this is a contemporary cardiovascular cohort. In any cardiovascular service you go, and you look at patients who have diabetes, either newly diagnosed or diabetes from before, at least a third of the population will have diabetes. So diabetes is much more common these days than if you go back to the 80s, and so is hypertension. Hypertension was about the third, and now you see, in this cohort, it's about 70% of the population. So about 40% had a history of previous MI. Some of them had PCI, about 15%. Again, and another 11% had CABG. So most patients ended up getting a stress test. This part is really not much different. So this is looking at what sort of patients in terms of the coronary angiography were enrolled. About 30% had one vessel disease, about another 40% two vessel disease, and about 30% three vessel disease. Very much similar to what was done in that CAS trial, what was done in that ESCC, the European study, and then in the VA study. Now, a good number of patients, about 30%, had proximal LAD disease, which is a marker of severity of disease. What I guess don't have here is they did have some people with reduced ejection fraction, but the average, the mean ejection fraction was actually normal. They did not enroll anybody who had EF less than 30%. That was an exclusion criteria. So these are people who have, even though they have significant coronary disease, the function of the heart has not been affected. And this is the result of the COURAGE trial. So you can see patients are followed up to 7 years, and grafts are essentially overlap. Overlapping almost completely. So in other words, at the time, back in the first decade of the 21st century, with first generation drug-eluting stents and a pretty good medical therapy, we were not able to demonstrate significant difference in outcomes between patients who were treated with medical therapy alone and patients who were treated with PCI and medical therapy at the same time. Now, one thing I got to point out is, please do not mix this up with patients who come with acute MI, whether it's a non-STEMI or a STEMI. This is, even though we use the same treatment, meaning revascularization in that population, there are a completely different population. This is not what we're talking about. Again, I want to stress, this is somebody who has stable coronary disease. Remember that vignette, so it was a patient with a month history of exertional chest pain. It wasn't somebody who came in with an MI. So here is the freedom from angina. I'm going to get through this quickly and not talk about the angina. So this is what they wrote in there, which kind of caught my attention when I was reviewing the paper for this presentation. So I'll tell you why it did. Let me read through that. Our findings reinforce existing, at the time, practice guidelines, which state that PCI can be safely deferred in patients with stable CAD, even in those with extensive multi-vessel involvement and inducible ischemia, provided that intensive multifaceted medical therapy is instituted and maintained. And that's important. So we're not talking about just a little bit of, a 40% coronary lesion somewhere. It is okay to delay and to defer and treat patients with stable coronary disease, even if it is extensive. Remember, 30% of this population had 3-vessel disease. 30% had proximal LAD disease, and as I said, encouraged it had to be more 70% or more proximal LAD disease. So those things are important to have in mind. You can have severe coronary disease as long as it is stable. You don't have to rush into that. You can essentially treat patients and then see how things go. Optimal medical therapy and aggressive management of multiple treatment targets without initial PCI can be implemented safely in majority of these patients. And 2/3 of whom may not require even a first revascularization during long-term follow-up. So essentially, a lot of these patients may be managed medically and followed closely in a shared decision-making process, but revascularization is available and offered to some of these patients. And I'll show you that data a little bit later on, but when it says 2/3, this is talking about the arm that was randomized to optimal medical therapy alone. In CARDIO trial, there was about 30% crossover. So these are patients that were randomized initially to optimal medical therapy, but during the follow-up ended up getting a PCI. And so obviously this was, when the trial was done, like a lot of other trials, the treatment that patient got was at the discretion of the treating physician, and at times either patients continued to have symptoms or the treating physician felt like they had to go ahead and offer PCI to these patients. Now this is a follow-up study of the CARDIO trial that was published, showing us the result up to 12 years of follow-up from 7. And the result was unchanged. You can see the graphs are overlapping between the PCI plus OMT arm and OMT arm alone. Okay, so the Berry 2D trial was another one. As I said, this was simultaneous. This was in patients with diabetes, so that's the difference. About 2,400 patients, and they were randomized to revascularization plus optimized medical therapy or optimized medical therapy alone. Again, very courageous, I would say, primary outcome of all-cause death. And this is how they essentially went ahead. They stratified patients, decided some of them were going to go to CABG stratum, and some of them were going to go to PCI stratum. And then here is when they actually got randomized. So a peculiar design in a way of the way this was done, but patients were not randomized to CABG versus PCI. This wasn't a comparison between different revascularization methods. This was only a comparison between revascularization and medical therapy. There was a heart team there that decided, which one of these stratum the patient would go to. If they felt like the patient is more appropriate for CABG, they would go to the CABG stratum and get randomized. And if they thought that the patient were more appropriate for PCI, they would go to PCI stratum. So again, very similar group of patients that were enrolled this time, as opposed to 30% being diabetic, 100% were, because that's how the study was designed. 10 years worth of diabetes. So you can see on average, these were long-standing diabetics. You see the A1Cs over here. And history of MI, a history of CHF, all of that other stuff very similar to CARDIO trial. And this is essentially the result. So you can see the p-value is 0.97. So the 5-year death rate, now remember this was a a primary outcome, for the group receiving revascularization plus OMT was 13.2% versus 13.5%. for the patient who received optimal medical therapy. I'll go back to just show you about 700 patients were in CABG stratum, right? So 380 here, 370 CABG plus medical therapy. About 1,600 patients ended up getting PCI, almost in half. PCI versus medical therapy. So these patients were treated with CABG, were treated with PCI. Now sort of you can see, well, maybe it doesn't make any difference how you revascularize, at least to some extent for the purpose of this talk. Here we go. Again, same thing. I'm just showing you the Kaplan-Meier curves. As you can see, no difference. And when you look at each one of the stratum, this is the PCI stratum, this is the CABG stratum. Again, same thing. You really don't see any difference. So by the time these studies were published, people started taking notice. So the blue graph here is essentially the growth of cardiac catheterization, which this is around the time sort of this idea was being floated. And so you can see the time point 2005, and when the next time point arrives here in 2010, CARD was published in 2007. And so you can see that people noticed that, well, maybe we should not necessarily do heart cath that often. This one, the PCI, that green also shows you the same thing. So people started noticing that, well, maybe we can just treat patients with, medications, and reserve PCI for later on, at least delay PCI and at least see how patients do in the beginning. Now, this is a meta-analysis of all the major. Now, I showed you COURAGE and BERRY 2D. There are a couple of other studies here that's smaller and less important, but they were all put in one meta-analysis. And all of these outcomes were, separately looked at. As you can see, all of them cross 1, which means that they're not statistically significant. And you can see overall p-value of 0.42. This one is pretty close, non-fatal MI, 0.06, but still not positive. Here you see unplanned revascularization, p-value of 0.14. And over here for angina, you see a p-value of 0.67, suggesting that necessarily in terms of controlled into chest pain, when you look at everything, it's not necessarily a revolution, let's say, in controlling patient symptoms. Now, what was the issues with CARD trial? It was actually done very well. It was very difficult for people who actually designed and implemented this trial. First time such a study was actually done. It was in heydays of coronary angiography. We had data that supported use of PCI in acute MI. We just sort of extended that data into stable disease. The thought process a lot of times was, well, what you have is coronary stenosis. It doesn't matter if you have a thrombus in there or if you don't have a thrombus in there, you probably will have the same benefit. So you can imagine there was a lot of resistance against enrolling these patients in a study. A lot of people felt like they're not serving their patients by allowing them to enroll in such studies. But nonetheless, this was done, and it was a landmark trial, probably one of the most important trials in cardiology ever done. Some pitfalls there, though. There was a significant proportion of patients that crossed over. So 32% in COURAGE, about 42% in BERRY 2D, just within that, initial 5 to 7 year follow-up. And so people said, well, with crossover, what you end up doing is you're going to dilute the treatment arm. You're going to dilute the arm that offers the invasive therapy when you have a lot of your patients. Remember, these are intention to treat analysis. So a lot of these patients, when a lot of them do cross over from the OMT arm to revascularization arm, you may essentially, dilute that effect. The other argument was majority of patients in the PCI group were treated with bare metal stents. So in COURAGE, just at the end of that, they started using these first-generation drug-eluting stents. In fact, 97% of the stents in COURAGE trial were bare metal stents. I think I misspoke in the beginning when I said they were only Taxus or that first-generation drug-eluting stents. It's not 97% were actually bare metal stents. In Berry 2D, in that PCI stratum, again, 66% were bare metal stents. So in Berry 2D, when the first generation drug-eluting stents became available, they essentially used them 100% of the time. But by the end of the trial, they had about a third of patients treated with them, and the rest were bare metal stents. So that was the other argument against these. They were also concerned that people were also concerned about selection bias. So these patients were initially underwent angiogram, and then they were randomized. So people felt that the most severe patients would have never made it into this study because their physician felt that this is not appropriate for them. So in other words, they thought that the Courage and Berry 2D ended up enrolling patients that were selected and were not necessarily patients with the highest burden of atherosclerosis. Again, same thing here. Not enough, high-risk patients were enrolled. Sort of same thing that I've mentioned here, both from the anatomy standpoint and from any other standpoint. If the impression was if the treating physician felt like this patient is, so to speak, too sick to go into a trial like this, they may not have been enrolled. Along with that, more data suggested that maybe if you have a significant amount of ischemic myocardium, then you'll benefit from revascularization, but if it is less than that, you will not necessarily benefit. So this study, observational study, suggested that you need at least 10% ischemic myocardium to actually benefit from revascularization. So anything less than 10%, and there's no difference between medical therapy and revascularization. So this is, as you can see, cardiac death over here, and that cross point is at 10%. So beyond 10%, you see that the two graphs essentially diverge. So those pitfalls that I talked about, this observational data suggesting that, well, you need maybe a more significant amount of ischemia before you can have any benefit. On the other hand, data from subgroup analysis from Courage, didn't really agree with that. So this is 189 from the Courage cohort who had moderate to severe ischemia, and as you can see, there's no difference between the OMT and PCI plus OMT. So this is the mild ischemia, this is the moderate to severe ischemia, and both graphs are essentially the same. Now, obviously, this is a very small population, but this is sort of having that clinical equipoise. You have arguments against what was done in Courage trial plus other observational studies that suggest there may be a population that will benefit from revascularization, and then you have opposite to that argument that that is not necessarily true. So that's how we essentially get to the next trial that I'm going to talk about in a quick minute. Quickly in Courage and Berry 2D, proximal LAD more than 50% was not an independent predictor of death and MI. So this is that sort of equipoise that I talked about. Having a proximal LAD disease, it did not suggest that you would have worse outcomes. So this goes against that argument. Well, maybe if you have more severe disease, you start having having benefit. There was no suggestion that PCI or proximal LAD reduced the risk of death or MI, and hazard ratio for PCI versus OMT was similar for proximal LAD versus other stenosis. Just quickly to show you, the patients that were in Courage trial, again, remind you, 3-vessel disease, about 30% of the population, and when you look at that subgroup analysis, you don't see any difference between 3-vessel disease, and 1 or 2 vessel disease. So here's that clinical equipoise that brings us to ISCHEMIA trial. ISCHEMIA trial was designed essentially to answer
those concerns and those questions. So they wanted to have a large trial. Courage enrolled about 2,000 patients. They wanted to have a large enough population that they don't run a risk of an underpowered study. So they enrolled about 5,200. They were planning to enroll about 8,000 patients, but they realized that's going to cost them about $200 million. This is, by the way, ISCHEMIA Trial is the most expensive NIH-sponsored trial in the history of the NIH sponsoring any type of research, really. So it cost about $100 million to run ISCHEMIA Trial. So a lot of work and effort was put into this. But nonetheless, they ended up at 5,200 patients. They had moderate to severe ischemia. That was to address one of those major points that I just pointed out. And they were randomized to initial invasive strategy. And this wasn't, as opposed to Courage, this was allowed to be CABG or PCI. And optimal medical therapy was essentially standard for both group. So either invasive strategy and OMT, or OMT alone. Now, if OMT failed, these patients were allowed to have revascularization or angiography and PCI. The primary endpoint was a composite of death from cardiovascular causes, MI, hospitalization for unstable angina, heart failure, and resuscitated cardiac arrest. As I said, that selection bias that was argued, they tried to address that, and I'll tell you how they did that. Previously, there was no minimum threshold for ischemia. That observational study that suggested you need at least 10% ischemic myocardium. Drug-eluting stents that were not used as much in Courage and Berry 2D. There was no FFR. FFR is a method of quantifying coronary stenosis. It shows you the drop across a stenosis in the pressure. And so this was not used. And in Courage trial, there was no CABG that was done. It was only PCI. So all of those were addressed in this trial. And the question they were trying to answer is, well, the magnitude of stress-induced myocardial ischemia can identify patients with a worse prognosis in whom revascularization could improve death and MI, and therefore, people who have at least moderate ischemia on a stress test, we want to see if revascularization is going to be beneficial. So I think I've addressed this. This is the design of the study. So people got that stress test done. Now, because they wanted to make sure people don't get excluded, that selection bias is addressed, they essentially came up with a CT coronary angiography as a way, a blinded CT coronary angiography, as a way of sort of blinding the enrolling physicians to the coronary anatomy so that they don't kind of take away these patients with more severe disease from the trial. So this was done, the local investigators were blinded to that. This was analyzed in a core lab. If patients had left main disease, they were excluded. Because left main is not what we're talking about. We were talking about stable ischemic heart disease, but we're not talking about left main disease. So patients who had left main disease were excluded from the trial. But if patient had any other situation, they were essentially enrolled. So 73% of patients got the CT angiography. The main reason patients didn't get that was people who had chronic kidney disease. They wanted to avoid the contrast and the risk of kidney injury. But most people nonetheless got that. And then they were randomized to the two groups, as we talked about. So this is, again, the same design. So that blinded CT scan with the core lab. They screen failed if they had left main disease. About 500 patients screen failed. And then they got randomized. About 3.5 years of follow-up. And we talked about the primary endpoints and everything. Now, hypertension and diabetes, because they were trying to get a sicker population, they ended up now getting 40% of people having diabetes, about 70% having hypertension, which is not different from Courage or Berry 2D. Again, the ejection fraction was normal, so I want to stress that. Same in Courage, same in Berry 2D. These are patients who have normal ejection fraction. We'll touch upon people who have reduced ejection fraction and stable disease. It shows you that now here, in Cardiology trial, about 30% had 3-vessel disease. Because they were trying to enroll a sicker population, they ended up about 45 to 47% of patients, having 3-vessel disease. So that's that almost half the population that were enrolled in ischemia trial had 3-vessel disease. In Cardiology trial, you had about 30% proximal LAD. This got up to about 46 to 47% over here. Right, the LAD involvement by itself was about 90%. So really, as good or as sick of a cohort as you ever get in terms of the burden of atherosclerosis. So here's what happened. So obviously, this is the red bar is people who were randomized to invasive strategies. So almost all of them got hard cath, right? This is the cardiac catheterization. And throughout the course of this study, about 28% of patients on conservative crossed and ended up getting a hard cath. When you come to revascularization, about 80% on the invasive strategy got revascularized. About 20% were not revascularized. These are patients that, for one reason or another, were deemed to be not a good candidate for revascularization. On the other hand, there was about a 23% crossover. So if you remember, in Cardiology, we had about 32%. In Berry 2D, we had 42%. So despite all the efforts they made, they still had some crossover. But again, I want to impress upon you, this is probably as good as you can ever do for a study of this magnitude. Given the contemporary practice in cardiology today and for cardiologists these days, it is very difficult to not offer coronary angiography to a patient that has significant coronary symptoms or significant symptoms. And so it's not surprising that you'd see these patients cross from one arm to the other at the discretion of the treating physician. Okay, so so it has the indications for why people got cath. Some of them they thought that they had a heart attack, about 14%. OMT failure or non-adherence was about 8%. And revascularization at 4 years was not preceded by a primary endpoint. So this means that some of these patients who got revascularized really didn't have an MI. They just, because of that chest pain, they went to the cath lab and they ended up getting a stent. So about 26% of these people ended up getting CABG. And about 74% ended up getting PCI. From the revascularization arm, remember, about 80% got revascularized. 20% were not revascularized for one reason or another. Again, 1/3 had extensive disease that was unsuitable for any mode of revascularization. That's again, I want to impress upon you, very well done study. So this is the outcome. So in the beginning, red is invasive strategy. And as you can see, about 6 months into the study, there was a 2% difference in outcomes. And this is because of the procedure-related complications, procedure-related MI, unstable angina, all of that. But then about at 2 years, the two graphs here cross, and they start to diverge, get into about 5 years. However, even though there's about a 2% difference between the two groups over here, when you look at the totality of this study, in fact, minus 2% at 4 years over here, the p-value is 0.34, so not a statistical significance between the two groups. So we're seeing essentially the Courage and Berry 2D replayed for you. Now, when you look at the death, which is the most important, outcome that we always pay attention to, essentially no difference. Myocardial infarction, you see the same as the primary outcome. And when you look at, you break it into peri-procedural MI versus spontaneous MI, something emerges. You notice that it looks like invasive strategy does reduce, a spontaneous MI. So this is a type 1, type 2, type 4B. These are stent-related after stent, and this is after CABG. P-value of 0.01. However, this is 5 years, right? It takes about 5 years to show this difference in MI, and you don't have any difference in mortality. So the argument here is takes a long time, and your MI is not the type of MI that patients die with, right? This is the sort of subgroup analysis. So you can see, again, severe ischemia or three-vessel disease, they're essentially the same. You don't see any difference between the two. Again, proximal LAD, no difference. And repeat is essentially a repetition of what we saw in CABG trial. So obviously it was an unlimited, unblinded trial, which is, there's, I guess, no way to have a blinded study of this sort. And this, doesn't apply again to patients with acute coronary syndrome and patients with low ejection fraction. So this is the way, if you look at the pathophysiology, this is what we come away with looking at these studies. It looks like when you have significant stable disease, even though you have severe obstruction, and they give you a positive stress test, they are not as much at risk of plaque rupture and an MI, whereas a lot of times your MIs, in fact, happen in these non-obstructive plaques. And so when we end up treating this group, the group that has a positive stress test with revascularization, but the risk of MI in this population is not as big as what we think. The risk is actually higher in a group that has non-obstructive disease. There's actually more data to support this. So this looks at a coronary stenosis severity in patients before they've had an MI. So these patients had an angiogram and later on present with an MI. So then their MI angiogram is compared with the previous angiogram. And as you can see, more than about 70% of these patients had a non-obstructive less than 50% stenosis. That's where the MI happened. It happened in a plaque that had less than 50% stenosis. 18% on a plaque between 50 to 70, and only 14% more than 70% stenosis. So we actually do have more data to suggest that it looks like most of the MIs actually happen not in those obstructive lesions that we treat with PCI or CABG, but in fact in plaque rupture happens most frequently in plaques that are non-obstructive. And so this idea of stenosis severity does not mean plaque vulnerability, right? Plaque vulnerability means if this plaque is going to be prone to MI, and it looks like that doesn't pan out. Now, this is a meta-analysis that has looked at, just published. The forest plots were too busy and difficult to read, so I decided just to put this statement above from what was new from the study. This is from Circulation. So cumulative evidence from meta-analysis of randomized trials. This included, by the way, CABG trial, included BERI-2D, included ischemia. It suggests that routine revascularization was not associated with improved survival, but was associated with a lower risk of non-procedural, meaning spontaneous MI and unstable angina, with greater freedom from angina at the expense of higher rate of pre-procedural myocardial infarction. And I showed you those higher rates of peri-procedural myocardial infarction. So it looks like if we offer revascularization to these patients, we may get a little bit less MI, right? But the mortality is not changed. And the price we have to pay is more peri-procedural MI, which, by the way, has been shown to have adverse outcomes at the same time. Now, I'm going to quickly go through a couple of other trials. This is the FREEDOM trial. This looked at 1,900 patients with diabetes type 2, published in 2012, that were randomized to CABG versus PCI. and the primary endpoint was death, MI, or stroke. And essentially, what they showed was CABG is better than PCI. It was a question for me for a long time as to, based on what we've seen, why there was no medical therapy. Again, I remind you, 30% of CABG patients had diabetes, and 30% of them had 3-vessel disease. In ischemia, we had, again, 40% diabetes, and 45% of the patients had 3-vessel disease. So how come there's not an arm for medical therapy? We're just comparing CABG to PCI, as if that means that we have to offer these patients revascularization. Again, remember, this is stable disease. So I finally managed to ask this question from the first author of a freedom trial. So Michael Farkou, he was here maybe about a year ago, did a grand round, and I asked him that question, and the answer was something I did not expect. So he said, when we designed this study, we did not have the result of CABG. We did not know. Our assumption was that we have to revascularize these patients. And so, it was essentially a choice between PCI and CABG. So it is very, now we practice on, freedom trial is frequently used in our contemporary cardiology practice, but has a major flaw, nothing that was deliberate, but a major flaw that you make when you read this study. What you come away with is, if I have a patient with diabetes and severe 2 or 3 vessel disease, I have to offer them something, and it's better to offer them CABG. And so that's an issue. Based on what I've presented to you so far. So just in the interest of time, I'm going to quickly go. Again, this is the MI. This is all-cause mortality from the freedom trial. And then the long-term survival showed the same thing. Another study, sort of same era, this is called STICH Trial, looked at 3-vessel disease and did the same thing, compared PCI with CABG. Now, I haven't spoken to people from this study, but I bet you that's exactly the same concept. They probably thought at the time when they were designing, remember, CABG was presented in 2007, and so these studies are, CABG, this one, 2009, reported 2009, they started this about 2002 and 3, and with Freedom Trial, in fact, they started the design of this study in early 2000, so they just didn't know what CABG showed. So now syntax shows the same thing. Now this is about 3-vessel disease. And that's what they did. They essentially randomized patients to CABG versus this drug-eluting stent, the first-generation drug-eluting stent. And even though the first year there was no difference, later on at 5 years there was a difference. So CABG was better, p-value of 0.03 than PCI. And so that's the state of the contemporary practice of, if you were to offer revascularization to patients with diabetes and severe coronary disease or 3-vessel disease, you want to offer them you want to offer them CABG over PCI. Same with MI, death, MI, and the composite outcomes. So now, is there any role for revascularization? So far, I'm telling you, if you have significant coronary disease, you can treat these patients with medical therapy. Revascularization is available to you. You don't have to rush into that. Yes, you do prevent some MI, but that's going to cost you some other forms of MI. So it's probably wise to start treating these patients with medications, see how they do, and you can always offer them coronary angiography and revascularization. But the exceptions are left main disease. Remember, left main disease was never studied. Left main disease was essentially determined from early 80s that because of those natural history studies, the patients who were not revascularized did very poorly, and nobody questioned that again since then. I can tell you nobody dares. There's really not good randomized trial data about stable disease versus about OMT versus revascularization. But I can tell you nobody dares doing that. I don't know that you're going to be able to get this through an ethics study. And the argument is, Well, we know that we get a little bit more MI if we don't revascularize, and getting an MI in left main frequently may mean that patients will have sudden death. And so there is good argument as to why left main disease has been always excluded. Three vessel disease with reduced ejection fraction, that's not what we looked at. I'm going to quickly show you some data before I run out of time. And again, some other three vessel disease, again, I showed you freedom data. And for some patients who have, you can achieve symptom control, you may want to offer that. So this is the STICH trial. This looked at 1,200 patients who had coronary disease who were amenable. This is only a CABG trial as the mode of revascularization. But they had an ejection fraction that was reduced. And this was compared to optimized medical therapy. Primary endpoint was death. And so it wasn't, so it didn't show any difference in all-cause mortality. However, when they looked at, the per protocol analysis and some adjustment that they had essentially stipulated before, pre-specified before, a difference was noticed. This is the all-cause mortality as treated, so not per protocol, not intention treat, but as treated. And so it was actually reported as a negative study. However, later on they published the 5-year results, and the 5-year results suggested that if you have stable coronary disease and reduced ejection fraction, you will benefit from revascularization. It'll take a while though. Again, if you have an 85-year-old who has an ejection fraction of 30% with severe disease, you have to ask yourself, is this patient going to have an extra 5 years before they can actually recruit or reap the benefit of a major either CABG or revascularization? That's important to pay attention to. So yes, you'll benefit, but it'll take a while. So these are sort of the patients that we offer them revascularization. I'm going to stop there. I think I'm running out of time. I'm going to allow people to be able to ask some questions. Thank you for listening to my rambling today.
Thank you, Dr. Shahab, this is Garbage Sohi. Can you hear me?
I can indeed.
Okay. Well, wonderful job. Great review. There are some questions. One is that with the ISCHEMIA trial, all the people got CT scans. In our practice, we do not do CT scans, and our surgical colleagues are questioning it. In fact, one of the surgeons from Emory wrote a small article in circulation that came yesterday. He said, the way we are practicing now, we are missing surgical disease, which you have already defined. I have felt that too in the clinic, that we're not exactly doing what the ISCHEMIA trial did, since we are not doing CT scans. Now, in Europe, as you know, CT scans are very common. Every patient that comes for evaluation gets a CT scan, which we have not. So I feel uncomfortable frequently to treat these people the way is suggested, because I do not know what the underlying anatomy is. I cannot reassure the people that they will follow what the people in the ISCHEMIA trial followed, because exactly I do not know the underlying anatomy. So what happens is this: if they get a stress test and they have ischemia, and then you end up with two solutions, either a CT scan or a cath. Cath has its drawbacks, some vascular issues, but it gives you better information than a CT scanner. A lot of these people end up getting cardiac catheterization. In fact, there have been reviews. They suggest that you do cardiac catheterization first, and then apply the ISCHEMIA trial to the patient, and decide what they want, what the physicians want, and what you want. Before I finish, I want to say hello to Dr. DeFilippis. I saw him on the screen once. Okay, thank you, and please, if you can answer some of these concerns.
Sure. Excellent question. So what you're saying is, well, how do we know if we don't have left main disease? And I agree with you. That's a caveat with what we have. But there are a number of things that we can do. Number one is if you do a stress test and you have a small amount of ischemia, you don't have to cath these patients, or you don't have to assume that this is left main disease. If you really have an obstructive left main disease, you expect to have significant amount of ischemia. You know, again, that's what I've observed is essentially in the practice of cardiology in the last few years is, you know, small amounts of ischemia, you know, buys patients cardiac cath, which should not be like that. So that's number one. Number two is there any other way for us to know if the patient has left main disease? So one of the things I've done, if you don't want to do a CT scan, one of the things I've done is I've used coronary artery calcium score, which essentially is a non-contrasted CT and very easily done, as a way of looking for calcium in the left main. And that allows you to essentially figure out where your atherosclerosis sits when, you know, assuming this is a patient that you're seeing for the first time or has never had, you know, cardiac catheterization. So I think those two comments I make about the left main disease. We certainly have to you know, consider left main disease whenever we see a patient with symptoms of, you know, stable coronary artery disease, no question. But again, you know, from what I've observed, you know, we very frequently reach out for heart cath and for revascularization without taking our time to, you know, optimize medical treatment and see if we're able to improve patients' symptoms just by making sure we have their blood pressure controlled, making sure we give them a nitrate or a beta blocker, making sure that we encourage them to stop smoking, and so on and so forth. Frequently, we do, you know, a suboptimal job of controlling the risk factors and very quickly reach for, you know, angiography and PCI, and then this cycle of, you know, stress test PCI keeps happening. Without paying attention to what has evidence-based benefit for patients, which is, you know, optimized medical therapy.
Yes, very good. Thank you very much. Andrew, hello. Andrew, hello.
Say real quick, if anyone has a question, you can unmute your mic and ask, or you can type it in the chat area and I'll convey it to Dr. Ghafghazi.
Thank you, Gerby. Shahab, this is Andrew. I just wanted to say I thought it was an excellent presentation of a mountain of data. I really, really enjoyed it. It was a great presentation, and a topic that is, you know, applicable really across medicine in developed countries. Everyone's got coronary disease, and so I thought it was really great. Thank you.
I appreciate it. I didn't realize you were here. I'm glad you were able to log in and listen to my rambling. I can tell you that I am obsessed with this topic, and that's you know, what I'm trying to convey to our fellows, that, you know, we you know, if it is about patient-centered practice, we have to, you know, it's upon us to practice evidence-based medicine, and I think that means that, you know, I don't think we do adequate of a job of controlling risk factors, and by offering coronary angiography and PCI, we sort of a lot of times, you know, turn subjects into patients before it's necessary, and then this process keeps happening. In, you know, in addition to the cost, everything else that comes with that, and you know, this perception of, oh, I have, you know, it's these stents in here. And then what happens in the society, that people, it's become in fact difficult to convince sometimes patients that, you know, if we treat your risk factors, you'll do better than if we offer you coronary angiography, because they've seen so much of the other way that they, you know, they look at you and they think you are, you know, you're crazy that you're saying this, because, well, I've seen, you know, 2-3 other cardiologists before, and they thought that the best way to do this is to, you know, offer these stents. So, I mean, this is a major challenge we have in, you know, in practice of cardiology, no question. We're probably going to get a generation before we're able to hopefully practice this way of, you know, evidence-based medicine for coronary disease, which is so rampant.
Well, Shahab, I've always enjoyed talking about this topic with you, and this maybe we'll take offline, but I have a project now with a UofL resident looking at acceleration of native coronary disease with after bypass, right? And we talk about competitive flow, and the surgeon would never put a graft on a non-significant stenosis because of competitive flow, it'll close down. I think we don't think about it. Our young patients that we send for bypass surgery, there's now competitive flow from the vein grafts or the lima that will accelerate the native coronary disease. And as we know, especially vein grafts, really you don't get more than 10 or 15 years out of them. And so for our younger patients, I think this is a new area of interest, and would certainly love your collaboration on this project if it's an interest to you.
Absolutely.
Okay, just real quick, Dr. Ghafghazi, I have a question someone posted in the chat area. I'll read it verbatim here. It says, this might open a can of worms, but I'd love to hear your take on those who have stable, moderate CAD, who then have transient medical insults causing type 2 STEMI. Can you translate today's studies lessons to that group regarding our approaches to PCI? And what's your take on our therapeutic approaches for them as far as long-term benefit?
We have Dr. D. Philippis is an expert in type 2 MI and well published on that. But type 2 MI is essentially considered still stable disease. Now, one thing I want to draw everybody's attention to is if you look at the outcomes of patients who have type 2 MI, those outcomes are as bad or even worse than type 1 MI. So that's important to pay attention to. But that's not because of the coronary disease. It's probably because of the comorbidities that cause the type 2 MI. So essentially, type 2 MI should be treated as a stable coronary disease. No matter the degree of the disease, you would make the same decision for these patients if they had or did not have type 2 MI. Presumably, this is a patient with sepsis, so when the patient recovers and gets discharged and comes back to clinic down the line, you'll be treating them the same as stable disease. And during their hospitalization, if you are convinced it's a type 2 MI, you don't offer anything that is beyond optimized medical therapy to them.
Thank you, Dr. Ghafghazi. Does anyone have any more questions? All right. Well, Dr. Ghafghazi, thank you so much for this presentation. This was wonderful. I know everybody really appreciated it.
Thank you very much for everybody listening to me.
Yeah, thank you. And just let everyone know we have one more grand rounds before, actually, I'm sorry, we don't have one more grand rounds because next week is Thanksgiving. We return on December 3rd, and it will be gastroenterology presenting. It will be this year's Richard Redinger lecture series, and it will be presented by Naga Chalasani from Indiana University, and he'll be speaking about drug-induced liver injury. So that's December 3rd, 8 a.m. Right here. Again, that'll be GI with Dr. Chalasani from IU and this year's Richard Redinger lecture series. So we hope to see everybody back. And again, thank you, Dr. Ghafghazi. This was great. All right, thank you, everyone.